Yeah, there's a lot that comes on, other characters that come into play. And it's just, you know, over the years, for a long time, I wanted to, bring uh, um, a camera into the exam room so many times to just capture these many stories that we had. And so we've just gotten to the point where we're able to do that. And this is an ongoing developing process. And I played through all of the credits just to give the audience a perspective of a number of people that is behind, not only behind our regular operations, but behind putting this production together.
Great. So before we begin our Q&A, I just want to go over a couple of things for the audience sake. We don't take questions directly from chat. We ask that everyone raise their hand in Zoom. In order to do that, you're going to click on the reactions button, which is found at the bottom of the Zoom window, second from the right, and then you'll just click on the raise hand function in the menu that pops up. When I call you, I will unmute you and then ask you to state where you're from and your question. And then we just ask that all your questions are brief and on topic. So I actually have got some questions for you to get started. So what did you learn in your years as a cardiologist when you did a more conventional practice? And then how has that changed for when you switched over to more of a lifestyle focused practice?
The years I practiced as a conventionally, and I practiced as an internal medicine doctor, a cardiologist, and a cardiac electrophysiologist. And so I saw patients at pretty much every level of illness, from those who just trying to come in and prevent illness, to those who are on death's door. I took emergency room call for weeks at a time, months at a time. And so manage patients at every level. One thing I learned in private practice that over time, despite the improvement in our technology, the procedures, devices, the so-called improvement on medications, the patients continue to get sicker and sicker. And so despite all the effort and money that we were pouring into things, I saw firsthand how not only did it not have an effect, it's one thing the patient remained as sick, but it seems like the more money we spent, the sicker the patients became. And so I'm not saying that the treatments were making them sicker necessarily. Can't rule that out, but can't say that's the case either, but they certainly weren't making them better. And so when I realized this, and of course I started having my own health problems, working so hard taking care of sick patients, I certainly didn't want to take the prescriptions I was giving them. I knew it wasn't working. So that's when I started to look for something different. So, but the most glaring thing, and this was, in training, you sort of go from one rotation to the next. Once you start your own practice, and I left training into my own private practice, I noticed firsthand, I'd see patients month after month, year after year, they were just getting sicker. And so that was one thing that was very obvious. And so that was what led to me, one of the things that led to me doing something different.
Thank you. And was there any point during your career that you felt there was a turning point? I know that if you look at graphs of obesity, there seems to be kind of like a real upward trajectory in the 90s. Did you see during your career that there really was a turning point where the patients that were coming into you were sicker, were heavier, or anything like that?
Well, that's a good question. It just seemed to be so, in one way, it's almost like, you're hearing this little buzzing sound, but you don't hear it because you've been hearing it so long. And I have a distinct knowledge of when I was in medical school, for instance. Type 2 diabetes was something that we only saw in individuals who were in their 60s or 70s. And then in my training and private practice, we started seeing them in younger people. And so that was probably one thing that I noticed a big distinct difference that really caught my eye, if you will. The obesity problem was something that it was pretty much there a lot. And so I didn't notice it so much because it was just there so much. But diabetes was one thing that was quite striking. I also noticed that I was seeing younger patients. When I say younger patients, I was getting, parents trying to get special requests to bring their 17-year-olds and a 16-year-old. I saw a 17-year-old kid, and he was actually tall and lean, who came in with chest pain. He had early heart failure. His heart was beating around 35, 40%. And so I had to put him on a detox diet, and he got some improvement in his heart failure, but he was 17. So I started seeing these patients at very young ages, and I would partially jokingly say I'm starting to run a pediatric clinic. But it was something that I think maybe within 5 to 10 years of my practice, it became very obvious that, things were changing on the horizon. And they were probably changing before then. It was just that I started noticing it so much at that time.
Right. And now I want to talk a little bit about conventional medicine, stents, bypass surgery, statins. Do you recommend these procedures and interventions? And when do you treat with lifestyle? And when do we need, traditional medical intervention?
Traditional medical intervention can certainly be beneficial in the acute setting. So, for instance, if someone's in the throes of a heart attack, you should go to an emergency room, go to a hospital, be stabilized, get a coronary angiogram, get a stent. That's a clear-cut area where you can argue that there's some benefit. Even now, I'm not saying that's an absolute indication, but an absolute finding that someone in an acute setting will benefit over a stent over lifestyle. But it's clearly a setting where we know that an acute intervention can be beneficial. And the reason why I hesitate to say it's absolute, I'll explain in a minute. As far as statins and other medications, I've really backed away from routine prescription of statins. If you look at, granted, there's studies showing, reduction of LDL cholesterol showing some cardiovascular benefit. However, if you look at, long-term benefits, the numbers tend to kind of even out in the sense that, someone's on a statin for decades on end, that's probably not a huge benefit to their overall well-being and added addition to their lives, based on some, studies. So that's one. Two, there are many patients on statin drugs who have, we're finding with, liver dysfunction, musculoskeletal problems, and the like. So it's having an increased added amount of morbidity to the patient's life. So we find that if we can put them on a natural lifestyle intervention and lower the cholesterol that way, it's not only going to, nutrition has a pleiotropic effect. It reduces cholesterol, reduces inflammation, reduces other type of problems, improves microbiome, et cetera, if you're on the right nutritional regimen. So there are multiple effects that are working synergistically as opposed to one drug that's doing maybe one or two things. And that's one. Two, which is very important, the addition of a medication, in my opinion, never comes without a side effect. Now, you may say, well, I take, medication X, Y, or Z, and I don't have any symptoms of whatever. However, you may not feel those side effects, but there's some biochemical process that's happening inside that's adversely affecting your system. Whether you're taking a proton pump inhibitor that's impeding your absorption of magnesium, that's then causing hypertension or poor sleep or whatever the case may be. So, all these drugs have biochemical effects that have underlying adverse effects that we're not detecting. In fact, the person who's most fortunate, the person who take a drug and they turn purple after the first dose, then they stop it right away, because that way, they don't have to suffer the underlying problems that medication will cover as well.
Thank you. So at what point would you ever say to a patient that it's too late for diet and lifestyle and you need a medical intervention like a stent or bypass? A patient who's not willing or for whatever reason not able to follow an aggressive nutritional intervention. So an aggressive lifestyle intervention. So, if you're not willing to follow or not able for whatever reason to follow the regimen, the things that I outlined, then we're going to prescribe the conventional things. And we do that, quite frequently because, we give our patients a choice, in other words.
I'm not, absolutely down against, prescription of medications and surgeries and all. I just don't think that they're that effective. I think a more effective approach is, approach of, optimal nutrition and the lifestyle intervention. Sort of like saying, well, hey, I've got to take a trip and drive to Los Angeles from Houston. And I said, well, I've got a race car you can drive, or, I have a broken down bicycle, 2 flat tires. Which would you prefer? And, some people prefer the broken down bicycle, 2 flat tires. I mean, I say, that's fine. It's all yours. So it's a matter of I look at it as a team effort. So, I'm not the end all be all. Sometimes people have a good reason they don't want to follow lifestyle intervention. So who am I to say that they're evil or bad? It's just, I'm passionate about it, but I'm not necessarily right all the time. So maybe for whatever reason, it's better for them to do the conventional approach, take the conventional approach.
And how do people respond, percentage wise, when you offer them the 2 roads between lifestyle intervention and medications or procedures?
I don't have accurately measured statistics, but I think if I were to make a guess, today the number is somewhere around 3-to-1 ratio. And I apologize, my cleaning people just hit the all lights off button. Excuse me, let me turn this on. These guys, hold on. I'm sorry about that.
No worries.
But anyway, you can edit that part out. So, but we have a skewed population because people, hear about what we do and the like, and so they come for that purpose. There's some who hear about what we do and they run far away. So, so it's a skewed population. I would guess 3-to-1 is the ratio.
Thank you. And going back to the cholesterol lowering drugs, are there, instead of doing them, are there herbs that you would recommend instead of those cholesterol lowering drugs?
There are some supplements you can use. So berberine, for instance, is a natural PCSK9 inhibitor, which lowers LDL cholesterol. You have these LDL lowering injections, which work, but berberine we use quite a bit. But, just talking about herbs, if you do things to clean the liver out. So my thinking of elevated cholesterol isn't simply a matter of eating fatty foods. I think of elevated cholesterol as an underlying sign of hepatic dysfunction or liver dysfunction. And so it's more of a metabolic problem than it is just, okay, I'm eating too much cholesterol. I mean, I'm eating too much cholesterol probably contributes to that. But, oftentimes it's really an underlying metabolic problem. So it's not just the fact that you're removing the bad foods, but you're cleaning up the person's metabolic process. Could the microbiome contribute to that? Could other things contribute to that? So I think it's probably more complex than what we make it. And so just to try to hit it with just one drug, in my opinion, is not enough. I always try to give my patients a chance off the drug, and we'll use something like berberine as an addition to help it out. But I think anything that helps, cleanse the liver and improve liver function, I think will improve overall metabolic function, then will also allow cholesterol levels to be normal. And sometimes an individual may have high cholesterol for whatever need. The body is compensating in many different ways. Cholesterol is a molecule that the body does use for vitamin D production or the like. So who's to say someone's cholesterol, LDL cholesterol or total cholesterol's at 190, it may be 190 for a reason. So, I mean, there's a metabolic process that's ongoing that we don't fully understand. So I don't want to just treat numbers, but rather look at the whole patient and treat the entire patient.
T. Colin Campbell, when he was speaking, had mentioned that people who were not breastfed tended to have a higher cholesterol, and there's research that explain, that shows that when they're breastfeeding, they have higher cholesterol as a little infant, but then their cholesterol tends to go down, and when they're not breastfeeding as an infant, their cholesterol stays low, but then goes up later on in life, and it stays higher. Have you seen anything like that or any research like that?
I'm not aware of that data, but again, it just, sharing that information underscores, at least two things. One, how our nutritional background has an impact on our nutritional presence. And then the other possibility could be that, breastfeeding may have some effect on the microbiome development, which could have effect on metabolism. So there are a lot of metabolic, processes that take place in our adult lives that are impacted by how we were fed as a child. I mean, the diversity of foods we ate as an infant, the amount of junk food we ate, et cetera, the amount of dairy we ate, how did that affect our gut microbiome that's, progressing now? So there are a lot of questions that can be raised, and many questions that are unanswered. And to simply just say, okay, let's treat this number with a pill, I think it's very short-sighted.